Hey there, curious minds. Welcome back to the Deep Dive, the show where we take your pile of information and unearth the most fascinating insights. I'm your guide, ready to help you navigate some truly vital information about your body's internal transport system.
And I'm here to connect those crucial dots, bringing you the why it matters and helping us think critically about what we learn. Today, we're embarking on a journey into one of the body's most intricate and, frankly, essential systems.
That's right. Our mission today is a deep dive into Unit 6. The hematologic system, drawn from Understanding Pathophysiology, the 7th edition by Huther and McCants and the team. We've got 3 core chapters to get through.
Yep, first, the fundamental structure and function of blood itself.
Then we'll look at alterations of hematologic function in adults.
And finally, how those same alterations manifest specifically in children.
Think of this as your shortcut, your audio guide to truly understanding your blood, its components, and the incredible balancing act it performs. You're going to walk away with some serious aha moments, so let's jump right in. So let's kick things off with the basics of what actually makes up our blood. It's far more than just, red liquid, isn't it?
Oh, absolutely. Picture your blood as your body's superhighway, constantly moving things around, defending, maintaining balance. About half, maybe a bit more, is plasma.
Plasma, that's mostly water.
Exactly. Mostly water, acting as the fluid matrix.
Right.
But it's packed with crucial solutes, especially proteins.
Okay, proteins, like what? What are their big jobs?
Well, the main one is albumin.
Yeah.
Think of it like the body's essential fluid manager, almost like a sponge keeping water inside your blood
Yeah,
vessels.
it's a sponge, right. So without enough albumin.
Fluid leaks out. You get edema, swelling. It's key for maintaining what we call colloidal osmotic pressure. Then you have globulins that do a lot. Defense, like antibodies, transport for fats, hormones.
Oh, wasn't there one for clotting?
Yes, fibrinogen. It's the precursor, the raw material, for the fibrin clot that actually stops bleeding.
Okay, so that's the liquid part. But what about the cells floating around in there? This is where it gets really interesting, I think. Red blood cells first.
Erythrocytes, yep, red blood cells. They're the most abundant, by far, nearly half your blood volume. Their main gig, tissue oxygenation.
And their shape is important, you mentioned.
Hugely important. They're these small biconcave discs. That shape gives them a massive surface area for grabbing and releasing oxygen. But even cooler is their reversible deformability.
Reversible deformability.
Yeah, they can literally squish themselves, like fold into a torpedo shape to get through capillaries narrower than they then just pop right back to their normal disc shape. It's amazing.
Wow, that is clever design. And inside them is hemoglobin.
Exactly. Hemoglobin, that's the protein carrying the oxygen, gives blood its red color too. Each hemoglobin molecule grabs 4 oxygen molecules.
4.
Okay, but here's a critical point. Carbon monoxide, CO, binds to that same spot on hemoglobin, like 200 times more strongly than oxygen.
Whoa, so it just elbows oxygen out of the way?
Completely hijacks the system. Very dangerous. And making these cells requires good nutrition. Iron, B12, folate are absolutely key. Deficiencies lead straight to anemia.
And they don't live forever.
Nope, about 100 to 120 days. Then they get old, fragile, and macrophages, mostly in the spleen and liver, take them out. But the body's smart, it recycles the iron.
Ah, the iron cycle. You mentioned a specific hormone regulating that.
Yes, hepcidin is made in the liver and acts like the body's iron traffic cop. It controls how much iron we absorb from food and how much is released from storage sites. Keeps things balanced.
Got it. Okay, moving on from red cells, white blood cells, our defense force.
Leukocytes, yes. Crucial for fighting infection, cleaning up debris. They're a diverse bunch. You've got granulocytes.
Granulocytes, meaning they look grainy.
Kind of, yeah, under a microscope. Like neutrophils, they're the first responders.
Yeah.
The may-eaters, phagocytes, in early inflammation. Then there are agranulocytes.
Less grainy looking.
Right, like monocytes, which become these powerful tissue macrophages, the big eaters. And lymphocytes, the T cells and B cells, the core of your adaptive immune response.
A whole specialized army in there.
Yeah.
And then platelets for clotting.
Exactly. Platelets or thrombocytes, they aren't even true cells, more like little cytoplasmic fragments broken off from giant cells in the bone marrow called megakaryocytes.
Fragments, but essential.
Absolutely essential.
Yeah.
They rush to an injury, stick together, form a temporary plug, and release factors that get the whole coagulation cascade going. They only last about 10 days.
So all these cells are circulating, but where do they actually come from? And where do they sort of gather?
Good question. That brings us to lymphoid organs and hematopoiesis, the continuous production of blood cells. The main factory in adults is the bone marrow, specifically the red marrow found in flat bones like your pelvis.
Red marrow. Is there yellow marrow too?
Yep, yellow marrow is mostly fat, inactive. The red marrow is where hematopoietic stem cells live. These amazing cells can become any type of blood cell.
And other organs are involved. You mentioned the spleen.
Right. The spleen is the largest lymphoid organ. It filters blood, cleanses it, kickstarts immune responses, and importantly, it's where many old red blood cells meet their end. You can live without it, but you're more prone to certain infections. Lymph nodes are filters too, but for lymph fluid, acting as surveillance posts for the immune system.
Okay. And this whole production process, hematopoiesis, is tightly controlled.
Oh, incredibly so. Red blood cell production, erythropoiesis, is dialed up or down by erythropoietin, or EPO.
EPO, the hormone kidneys make.
Primarily, yes.
Hmm.
If your tissues aren't getting enough oxygen hypoxia, the kidneys release more EPO, telling the bone marrow make more red cells.
And platelets.
Similar feedback loop. Thrombopoietin, TPO, mainly from the liver, regulates platelet production by controlling those megakaryocytes in the marrow. It's really elegant.
So putting it all together, how does the body actually stop bleeding? That's hemostasis, right?
Yes, hemostasis. It's this rapid, multi-step process to arrest bleeding. First, the injured vessel spasms, constricts. Limits blood flow immediately.
Okay, step one.
Step 2. Platelets swarm the area, stick to the damaged wall helped by something called von Willebrand factor, and stick to each other, forming a temporary hemostatic plug.
The platelet plug.
Step 3. The coagulation cascade gets activated. It's a series of protein reactions, like dominoes falling, ending with the enzyme thrombin converting fibrinogen.
The precursor protein we mentioned.
Exactly. Into sticky fibrin strands. These strands weave through the platelet plug, making a strong, stable fibrin clot, trapping other cells too.
And the final step, cleanup.
Kind of. Step 4 is clot retraction, pulling the edges of the vessel together, and then fibrinolysis, where the clot is gradually broken down by an enzyme called plasmin as the tissue heals.
How does the body stop this cascade from, clotting everything?
Crucial question. There are built-in brakes. The healthy lining of blood vessels actively prevents clotting. Plus, there are specific inhibitor proteins, like antithrombin, that neutralize clotting factors, especially thrombin. And the fibrinolytic system gets rid of clots once they're not needed.
And that breakdown product, D-dimer.
Right. When plasmin breaks down fibrin, it creates fibrin degradation products, and D-dimer is a specific one we can measure in the blood. High levels suggest there is significant clotting and clot breakdown happening somewhere, like in a deep vein thrombosis.
Okay, chapter 22 paints an incredible picture of a healthy system. Now, let's pivot to when things go wrong in adults. Chapter 23, this is where we really see the impact, right?
Indeed. We start seeing diseases of too few cells, too many cells, or cells that just aren't doing their job properly. Understanding the normal stuff is key to getting these alterations.
Let's start with anemia. You said it's basically an oxygen shortage.
That's the functional definition, yeah. A reduction in the total number of erythrocytes, or in the quality or quantity of hemoglobin. Bottom line, less oxygen gets to the tissue hypoxia.
Causing fatigue, shortness of breath.
Exactly. Symptoms depend on severity and how fast it develops. The body tries to compensate, heart beats faster, breathing increases, but eventually those mechanisms are overwhelmed.
And there are different types of anemia based on cell size.
Correct. We often classify them that way. You have macrocytic anemias with abnormally large red cells. The classic example is pernicious anemia.
That's the B12 one.
Yes, usually caused by the stomach failing to make intrinsic factor, which you need to absorb vitamin B12. No B12 means faulty DNA synthesis during red cell production, leading to big, fragile cells and often neurological problems too. Folate deficiency causes a similar macrocytic picture.
Okay, big cells. What about small ones?
That's microcytic, specifically microcytic hypochromic small cells with less color, meaning less hemoglobin. The prime example, and the most common anemia worldwide, is iron deficiency anemia, IDA.
Just not enough iron.
Often due to chronic blood loss, like slow GI bleeding or inadequate dietary intake. Classic signs include fatigue, pallor, sometimes weird things like spoon-shaped nails or cracks at the corners of the mouth.
Interesting. And then there's anemia related to ongoing illness.
Right. Anemia of chronic disease, sometimes called anemia of inflammation. This one's tricky. It happens with chronic infections, cancers, autoimmune diseases. The body has iron stores.
But it can't use them.
Exactly. Inflammation triggers increased hepcidin, that iron regulator hormone we talked about. Hepcidin locks iron away in storage sites and reduces absorption, so even though there's iron around, it's not available for making red blood cells. It's like the body is trying to withhold iron from potential invaders, but it harms itself in the process.
Wow, inflammation has such far-reaching effects. Okay, what about the opposite problem, too many red blood cells?
That leads us to polycythemia. It's specifically polycythemia vera, PV. This is a myeloproliferative neoplasm, basically a slow-growing cancer of the bone marrow where it just churns out too many red cells and often white cells and platelets too.
Driven by a gene mutation.
Often, yes, a mutation in the JAK2 gene. All those extra cells make the blood viscous, what we call a hypercoagulable state. Big risk for blood clots, strokes, heart attacks, and a really weird characteristic symptom is intense itching, especially triggered by warm water acrogenic pruritus.
Itching from water. Strange. And what about just inheriting an iron overload problem?
That's hereditary hemochromatosis, HH, an inherited glitch in iron metabolism where your gut absorbs way too much iron from your diet. This excess iron builds up in organs, liver, heart, pancreas, joints, causing serious damage over time like cirrhosis or diabetes. Treatment involves regular bloodletting, phlebotomy to remove the excess iron.
Okay, shifting to white blood cells again. Problems here can be about numbers, right? Too many or too few.
Exactly. Leukocytosis is a high white count, often a normal response to infection, but can be malignant. Leukopenia is a low count, making you vulnerable. A major concern is neutropenia, specifically low neutrophils. Neutrophils are key bacteria fighters, so low counts dramatically increase infection risk. Below a certain level, it's called agranulocytosis, which is extremely dangerous.
And a common condition affecting white cells is mono.
Right, infectious mononucleosis, IM, caused by the Epstein-Barr virus, EBV, spread typically through saliva, the kissing disease. EBV infects B lymphocytes, triggering a massive immune response. You get fever, sore throat, swollen lymph nodes. But the key thing pathologically is often splenomegaly.
Enlarged spleen. Why is that important?
Because an enlarged spleen is fragile. Even minor trauma, like in contact sports, could cause it to rupture, which is a life-threatening emergency. So no sports during mono recovery is crucial advice.
Got it. Now onto the more serious white cell issues, the leukemias.
Leukemias are malignant disorders, cancers originating in the bone marrow. Uncontrolled proliferation of malignant leukocytes crowds out everything else. You end up with too few normal red cells, anemia, too few normal white cells, leukopenia infection risk, and too few platelets, thrombocytopenia bleeding risk. That triad is called pancytopenia.
And there are acute and chronic forms.
Yes, acute leukemias like acute lymphoblastic leukemia, ALL, common in kids, and acute myeloid leukemia, AML, more common in adults, involve very immature cells called blasts. They come on suddenly, progress rapidly. Chronic leukemias, chronic lymphocytic leukemia, CLL, and chronic myeloid leukemia, CML, involve more differentiated but still dysfunctional cells and tend to progress much more slowly.
Is there a specific genetic link often found?
In some types, yes. For instance, CML is strongly associated with the Philadelphia chromosome, the specific translocation between chromosomes 9 and 22. This creates a fusion gene, BCR-ABL1, that drives uncontrolled cell growth. Identifying these markers is key for diagnosis and targeted therapy.
Okay, related but different. Cancers in the lymphoid system outside the marrow, the lymphomas.
Right. These arise from lymphocytes residing in lymph nodes, spleen, or other lymphoid tissues. A key distinction is between Hodgkin lymphoma, HL, and non-Hodgkin lymphomas, NHL.
What's the difference?
Hodgkin lymphoma is characterized by the presence of unique, large malignant cells called Reed-Sternberg cells, often infected with EBV. It typically starts in one group of lymph nodes, often in the neck, and spreads in a fairly predictable pattern to adjacent nodes. Systemic symptoms like fever, night sweats, weight loss, called B symptoms, can occur and usually mean a worse prognosis.
Then non-Hodgkin.
NHL is actually a much broader category with many different subtypes, mostly arising from B cells. It tends to spread less predictably and can involve sites outside the lymph nodes early on. Burkitt lymphoma is a particularly aggressive type of NHL, known as the fastest-growing human tumor. It's strongly linked to translocations involving the MYC gene and often EBV, frequently presenting with tumors in the jaw or abdomen, especially in certain regions of Africa.
Wow, fastest growing tumor. And then there's multiple myeloma. That sounds distinct again.
It is. Multiple myeloma, MM, is a cancer of plasma cells, the antibody-producing B cells, specifically within the bone marrow. These malignant plasma cells proliferate slowly, but produce huge amounts of a single defective antibody called an M protein.
M protein, you can measure that.
Yes, using serum protein electrophoresis, you see a big spike. These cells also often produce just a light chain part of the antibody called Bence-Jones protein, which gets filtered by the kidneys and can cause severe damage.
And it affects bones.
Profoundly. The myeloma cells activate osteoclasts, cells that break down bone, leading to characteristic occlusive lesions. They look like punched-out holes on X-rays.
Yeah.
This causes severe bone pain, high calcium levels, hypercalcemia, and pathological fractures. Anemia and kidney failure are also common. Overwhelming infection is often the ultimate cause of death.
Just devastating. Okay, quickly, what about the spleen itself causing trouble?
An enlarged spleen, splenomegaly, isn't always a disease itself, but a sign of one. If it becomes overactive, that's hypersplenism. It starts trapping and destroying too many blood cells, red cells, white cells, platelets, leading to cytopenias. Sometimes the only fix is removing the spleen, splenectomy.
But that has risks.
Yes, a lifelong increased risk of certain severe bacterial infections known as overwhelming post-splenectomy infection, OPSI, because the spleen plays a key role in filtering encapsulated bacteria.
Right. Lastly, for adults, let's cover hemorrhagic disorders, problems with bleeding.
Broadly, these stem from defects in platelets, primary hemostasis, or clotting factors, secondary hemostasis. Low platelet count, thrombocytopenia, is common. It can be due to decreased production or increased destruction.
Increased disruption, like an ITP.
Exactly. Immune thrombocytopenic purpura, ITP, is autoimmune. The body makes antibodies against its own platelets. Heparin-induced thrombocytopenia, HIT, is a reaction to heparin therapy, where antibodies form complexes that activate platelets, paradoxically causing clotting in low platelets. And thrombotic thrombocytopenia purpura, PTP.
That one sounds complex.
It is a rare but life-threatening disorder, where tiny clots form spontaneously in small blood vessels throughout the body, consuming platelets and damaging red blood cells as they squeeze past. You see fragmented cells called schistocytes. It causes a classic pentad of symptoms: severe thrombocytopenia, hemolytic anemia, neurological issues, kidney failure, and fever. Needs urgent treatment with plasma exchange.
What about too many platelets?
That's thrombocythemia or thrombocytosis. If it's due to a marrow disorder, like an underlying JAK2 mutation, it's called essential thrombocythemia, ET. Like PV, it increases clotting risk, but paradoxically can sometimes cause bleeding too. A unique symptom can be erythromelalgia, intense burning pain in the hands and feet.
And then there's the condition where you're clotting and bleeding everywhere.
The nightmare scenario: disseminated intravascular coagulation, DIC. It's not a coronary disease, but a complication of severe conditions like sepsis or major trauma. Something triggers massive, widespread activation of coagulation throughout the microvasculature.
So tiny clots everywhere.
Yes, blocking blood flow, causing organ damage. But this consumes all the platelets and clotting factors, so then the patient starts bleeding uncontrollably from everywhere else. It's a consumptive coagulopathy. Measuring high levels of D-dimer is key to diagnosis, showing that massive clotting and breakdown is happening.
A true emergency. And finally, just the general risk factors for unwanted clots, thromboembolic disorders.
We often talk about Virchow's triad: three main factors: injury to the blood vessel lining, like from atherosclerosis; abnormal blood flow, like stasis from immobility or turbulence; and hypercoagulability. An increased tendency for blood to clot may be inherited or acquired. Any combination of these ramps up the risk of forming a thrombus, a stationary clot, which could break off and become an embolus.
Phew, that's a lot that can go wrong in adults. But how do these hematologic issues present differently in children? Chapter 24. They're not just small adults, right?
Definitely not. Their developing systems, their baseline values, their common conditions, they differ. Some things are similar, some are unique.
Let's revisit iron deficiency anemia, IDA. What's the critical point for kids?
For infants and toddlers, IDA is the most common nutritional disorder, but the real concern is its impact on brain development. Iron is absolutely crucial for neurodevelopment, and deficiency during these critical early years can cause cognitive and developmental delays that might be irreversible. That's why screening and prevention are so important.
Irreversible damage. That's sobering. What about that mother-fetus incompatibility, HDFN?
Right, hemolytic disease of the fetus and newborn. The big one historically was Rh incompatibility, where an Rh-negative mom carrying an Rh-positive baby develops antibodies that attack the baby's red cells in subsequent Rh-positive pregnancies. Severe cases caused massive anemia, jaundice, even hydrops severe edema, often fatal.
But we can prevent that now.
Yes. The key insight is prevention with Rh immune globulin, ROJAM. Giving this shot to Rh-negative mothers during pregnancy and after delivery prevents them from forming those harmful antibodies in the first place. It's been a huge public health success. ABO incompatibility is more common now, but usually much milder.
Okay, what about sickle cell disease? We often think of that in a pediatric context.
Yes, it's an inherited autosomal recessive disorder affecting hemoglobin structure, producing abnormal hemoglobin S, HbS. Under conditions like low oxygen, dehydration, or stress, HPS causes red cells to distort into a rigid sickle shape.
And those sickled cells cause problems.
Big problems. They can't squeeze through capillaries easily, so they block blood flow that's vasocclusion. This causes excruciating pain crises, damages organs over time, stroke is a major risk in kids, and leads to chronic hemolytic anemia because the sickled cells are destroyed faster.
Are there different types of crises?
Yes. The painful vaso-occlusive crisis is most common. Sequestration crisis, where blood pools dangerously in the spleen or liver, can be fatal, especially in young children. And a plastic crisis, often triggered by a virus, causes a sudden drop in red cell production. Infection, sadly, remains the leading cause of death. Treatment involves managing pain, hydration, preventing infection, hydroxyurea to boost fetal hemoglobin, and sometimes transfusions or even curative stem cell transplant.
And thalassemias, also inherited.
Also inherited, autosomal recessive. Here, the problem isn't abnormal hemoglobin structure, but reduced production of either the alpha or beta globin chains needed to make normal adult hemoglobin, HbA. Leads to microcytic hypochromic anemia.
Beta thalassemia major sounds serious.
It is, also called Cooley anemia. Severely reduced beta chain production leads to excess alpha chains, ineffective red cell production, severe anemia, and iron overload from necessary transfusions. Kids can develop skeletal deformities and heart failure. Alpha thalassemia major is usually fatal in utero. Stem cell transplant is the only cure here, too.
Moving to coagulation. Hemophilias in kids.
Classic inherited bleeding disorders. Hemophilia A, factor VIII deficiency, and hemophilia B, factor IX deficiency, are X-linked recessive, so primarily affect boys. They lack a key clotting factor. Characteristic bleeding into joints, especially knees, elbows, ankles. It's painful and damaging over time. Muscle bleeds are also common. Any internal bleeding can be life-threatening. Treatment involves replacing the missing factor, often prophylactically now, with recombinant products.
And ITP, the platelet disorder. Different in kids.
Primary immune thrombocytopenia, ITP, is the most common platelet consumption issue in kids. Like in adults, autoantibodies destroy platelets. But the pediatric difference is that it's often acute and self-resolving. About 75% of kids recover fully within months, often after a viral illness. We usually just observe unless bleeding is severe.
That's good news. Finally, blood cancers in children.
Leukemia is sadly the most common childhood cancer, and the vast majority is acute lymphocytic leukemia, ALL. Similar mechanism to adult acute leukemia, uncontrolled proliferation of immature lymphoblasts in the marrow, crowding out normal cells, causing pancytopenia.
How do kids usually present?
Often with vague symptoms like fever, fatigue, bone pain, bruising, infections. Diagnosis needs blood tests and bone marrow examination showing those blasts.
Is treatment effective?
Remarkably so for all in children. With intensive multi-agent chemotherapy protocols, survival rates are now very high, over 90% in many cases.
What?
It's one of pediatric oncology's major success stories.
That's fantastic progress. And lymphomas in kids.
Less common than leukemia, but still significant. For non-Hodgkin lymphoma NHL in kids, Burkitt lymphoma is actually the most frequent type, unlike in adults. Remember, that's the really aggressive one, often with jaw tumors, and linked to MYC gene changes in EBV. Hodgkin lymphoma, HL, also occurs, more often in adolescents, presenting similarly with enlarged lymph nodes and those Reed-Sternberg cells.
Wow, what an incredible journey through the hematologic system, from the elegance of its normal function, the cells, the plasma, the clotting, to the sheer diversity of things that can go wrong in both adults and children.
It really is astounding. We've seen how interconnected everything is. A single gene mutation, an autoimmune attack, a nutritional deficiency, they can ripple through the system, causing profound effects on oxygen delivery, immunity, bleeding. It really drives home how vital this system is.
And also how resilient it can be with all those compensatory mechanisms and, thankfully, increasingly effective treatments. Thinking across this whole unit, what stands out to you as a key takeaway? Maybe something for our listeners to really chew on.
What strikes me is the sheer precision required. Think about the iron cycle, perfectly balanced by hepcidin. Think about hemostasis needing to clot instantly at an injury, but never clot inappropriately elsewhere. It's this constant, incredibly fine-tuned balancing act. And it makes you wonder
What?
how incredibly sensitive this system must be. With seemingly tiny, subtle insults, environmental exposures, chronic low-grade inflammation, maybe even lifestyle factors we don't fully appreciate yet, might be enough to slowly, insidiously nudge that delicate balance off kilter, setting the stage for disease years down the road. It just highlights how much every little component, every regulatory signal really matters for keeping that whole intricate highway running smoothly.
That is a provocative thought, a really testament to the complexity and maybe the fragility hidden within the marvel of the human body. Well, with that thought, you are now much, much better informed on the incredible world of the hematologic system. We hope this deep dive has given you some valuable insights and maybe sparked even more curiosity.
Thank you for joining us on this exploration.
And a special thank you, as always, to the Last Minute Lecture team for making these crucial insights accessible to all of you. We'll catch you on the next deep dive.